Hi, everyone, and welcome to the Tulsa World Opinion podcast. I'm Jenny Graham, the editorials editor, and I'm here with, I think I can call you an old friend, Mike Brose. I've known you a long time.
We've known each other a long time, Jenny.
So I think I started this job when you started your job at the Mental Health Association. And that was, he headed the Mental Health Association. Oklahoma now, was Tulsa when he started out, but you headed that for 25 years.
27.
And still, 27 years. Okay.
Yeah.
Ooh. And then but you're still a practicing clinician, and
Yes.
And you're teaching at ORU, correct?
I teach adjunct social work classes at Oral Roberts University. That's correct.
And just as important, you're a member of our community advisory board. So thank you for joining us and helping educate us and send us in the right direction. And
I've learned as much. I've learned as much from that as I hope I've given. So
yes, well, you wrote an op-ed that I'm bringing to people's attention if they missed it last Sunday, and you brought up homelessness, and there was something specific to it that I had never heard of, and it's a symptom I've never heard of called anosognosia.
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 Okay, anosognosia. I will probably mispronounce that at least 20 more times, so I apologize. But this was, I've never heard of this symptom before, but the way I understand it, the way you presented it, is that it is when a person doesn't recognize they are mentally ill. They are not aware of their disorder while everyone around them does. And that's really important to sort of talk about this in the context of homelessness. Can you explain a little bit about the background of when clinicians started using this as a separate symptom as it relates to homeless people, and also why is it referred to as a symptom rather than a diagnosis?
Yeah, that's all a great question there, and I'm going to try to unpack this a little bit. Okay. So when I started working in 1993 with the Mental Health Association, we're a mental health education, mental health advocacy organization. We had many interactions with people who were in treatment with their serious mental illness, or not in treatment with their serious mental illness, or in some sort of transition about that. Now, when we use the term serious mental illness here, that's code for schizophrenia, schizoaffective disorder, and bipolar disorder. Okay, so make sure that your viewers, listeners understand when we use that. You'll hear me use that term, serious mental illness. So it was really pretty early on, I began to notice this phenomena. These people didn't even seem to have any awareness they had any kind of mental illness. Right. And I was like, what? And I was talking to, and I really give my friends at NAMI, National Alliance to Mental Illness, I really give them a lot of credit, because as an advocacy organization themselves, as family members, again, lived experience. Clinicians don't know everything, Jenny. We think we do. We like to sell we do. People with lived experience, man, they know. And it was a gentleman, a father, and I was talking. I said, man, we're trying to help this guy. He was in the office. I was in the office. I said, trying to help this guy. The problem is he doesn't even seem to even be aware that he has a mental illness. And this dad goes, well, you know what that is, don't you? And I go, no. And he said, well, it's called anosognosia. And I said, well, I've never heard that. Hey, I've been practicing social worker for a long time, licensed. I never heard that term. So I began to look it up and research it. And then I found that it has been used over the neurological side of mental health, of medical care for a long time. Stroke recovery victims have it. People with traumatic brain injuries sometimes have it, where they have no awareness whatsoever there's anything wrong with them. Well, it turns out that people with mental illness, serious mental illnesses, oftentimes, the research shows, roughly about 50%. So not everybody has it, about 50%. That's still a pretty significant number, percentage. And they also have it. And the thinking right now is, and there's a growing body of evidence that these illnesses, just like stroke victims, traumatic brain injury, it actually damages the structure of the brain itself, right? So it turns out the thinking right now is that these serious mental illnesses, for some people, it actually does some damage to the same area, frontal and right frontal lobe of the brain. And in there is where insight And so they lose any insight or awareness. So in their minds, they are perfectly normal,
Okay.
although it's painfully obvious to everyone around them. So Dr. Xavier Amador, who we're bringing to Tulsa, by the way, for a training and workshop in February 28th, just mark that on your calendars. He's going to be here in town. We're bringing him in, and I'm working with the Tulsa Day Center and with Grand Mental Health. We're bringing him in and to do a training, but he was the one who's a trained clinical research psychologist at Columbia University. He didn't learn it as a clinician, by the way. How did he learn about it? He had a brother, his brother Henry, who had a serious mental illness, and he began to identify it, and then he began to research it and discover this. But the evidence is that it actually damages that part of the brain, frontal cortex, right side lobe, where insight is apparently at, and they have no awareness. So he had to completely rethink, and it is a symptom. It's not in itself a diagnosis; it's a symptom. But it's a symptom, Jenny, we have ignored. The clinical community has ignored and or not understood. It becomes a huge barrier. And the interesting thing about it, here's the deal: all the other symptoms, common symptoms of schizophrenia, schizoaffective, bipolar when it's untreated, all these they're untreated, paranoia, delusions, things that we normally know. And when they get treatment, when people get treatment, the paranoid thinking, auditory hallucinations, sometimes people have visual or olfactory hallucinations, but very common auditory hallucinations, more common delusions. They'll believe things that aren't true, what have you. Those symptoms, when they get treated, actually will abate. They will begin to reduce, but non-anosognosia.
So with anosognosia, I want to make clear that what this is it's referring to, these are the people who, when you think of chronic homelessness, the general public, they're the ones you see crashed out under a bridge. They're the ones who are ranting on the sidewalk, who people think, I'm a little scared of that person because they're just not in their right minds. Because you had mentioned the 15%, most, and this has sort of been borne out, that you take all the homelessness in Tulsa, yes, we're talking only 15% of that. All the other people, we have services that are getting served. They'll get back on their feet, and they may not have mental illness. So we're talking 15% of people who are getting up to 80%, take up 80% of the frontline resources. The ones that's just a revolving door, because they
first responders.
If you don't know you're ill, you don't stay on treatment, right?
Yeah. Homelessness
so
related
for this, then, if it's an actual brain disorder like that we can research in the brain, is there something neurological? Is there a treatment for this?
Yeah, Amador talks about, he calls it his LEAP method. It's an acronym: listening, empathy, acceptance. Usually we try to talk people out of what they're thinking and feeling, acceptance, and partnering. And so actually gives a chance for trust to develop. And so now, again, I want to just, very important distinction here, Jenny, just because people will, when they hear this, as I said earlier, about roughly 50% of people with these serious mental illnesses have anosognosia. Most of them are not on the streets. Oftentimes they're living in housing. Oftentimes they may be living with their adult parents, but the parents or their family members recognize the anosognosia all the time. But because of the complexities of this illness and this symptom, a certain small percentage of this will end up homeless. That's why it drops down to about 15%, because
15,
people become homeless because people in the homeless population become homeless for many, many reasons. The number one, I think, is eviction. They lose their housing. They can't afford their housing. And once they're shut out, they don't have any money to get back into that system. It's expensive to get back into that into an affordable housing system once you're out of it. But with anosognosia, there's nothing wrong with me. In Amador's book, this is very important. Amador, what's the name of his book? He names it so perfectly. I am not sick. I don't need your help. So on the street, outreach workers are trying to outreach these people. there's nothing wrong with me. Leave me alone. And because they're so resistive to, there's nothing wrong with me. They don't see it.
Right.
Then the homeless outreach workers, there's someone standing right over here who doesn't have anosognosia, who's going, help me, help me. I want to get out of my homeless situation. Where are they going to put their time in?
With the person
So
who wants to help, right?
that's right. So these people get lost because they're so hard to work with. So that's why we're looking at New York. And I write about it in the article. We went up to New York because we read in the New York Times the story about the mayor's office, the police department, and private providers, homeless outreach providers, are all working together to target this particular subset of the homeless population that are responsible for so many first responder calls that's related to homelessness.
So
That makes sense?
It does. And you mentioned New York City, which I think is always interesting because people don't necessarily think of that as being, there's so many different demographics between New York City and Tulsa that can we really replicate something out of cities that are that much larger? Why did you choose New York City? Are there other cities that are sort of addressing this population through that?
We don't know of any other city that there may be some, but we don't know who they are. We just know New York City was, and it was really amazing. It's a different scale, but it's exactly the same problems. And we can get into one of the key differences we discovered is how the police department and the mental health community and these individuals interact in New York City in comparison to Tulsa and many other cities. I'm not just picking on Tulsa Police Department. I'm picking on a lot of police departments, and I'm going to say picking on them. I don't think we really understand this, and that's what we're trying to do. That's what we were trying to learn. And we went up there. We're sitting there in the Department of Homeless Services in New York City. They brought all their top people out. And by the way, Mayor Adams there, his top person on homelessness is right next to him. And he came over from the mayor's office and chaired the meeting with us. They brought out their top people. There's 4 of us, and we're all sitting there talking the same language. They actually were really impressed with us that we understood what the language and what they were talking about and what they were trying to do. They were very impressed that you guys get it. And then we started comparing notes, and that's when we got into it. There's a key difference in how the 2 police departments work with this population.
And what were those key differences, do you think?
So if I'm out and I'm a street outreach worker and I'm licensed here in Oklahoma, in Tulsa, Oklahoma City's the same, and I'm working out there, I'm doing street outreach, and I've got somebody. Now, they're not imminently, and here's the word, imminence, they're not imminently a danger to self or others, but they are deteriorating. And this is their target population, those people that we see. They've been out on the streets forever. They won't go into the shelters. There's nothing wrong with them. We can watch them deteriorate. They're dressed. They're not taking care of themselves. They're physical and mental health. They're just out there. They're laying on the streets. They're walking down, talking to themselves. The population is 15%, 15 to 20% that we're talking about. They're almost always alone. Many people in the homeless community have their own little network, or they have their little groups that they hang with, just like you or I do. But for these people, they're almost always alone. And so that they've watched them deteriorate. And everybody, the police department on the street knows who they are. The homeless outreachers know who they are, but we can't seem to get them any help because they're not imminently at danger to self or others. But in the Oklahoma 43A law, there's what's called the deterioration standard. And it talks about if people are deteriorating and they can't take care of their daily activity, their daily living, their health care, their self-care, what have you, they can't. And it's really obvious to everybody that you can use it if you have to, and they won't accept treatment again. And that doesn't mean we're not trying to get them. Hey, we're trying to use the LEAP method that Dr. Amador talks about. We're trying to build a relationship, but it may fail. And we've got a woman, we just recently, she was outside a downtown business. their business was calling the blue team and wanting our help, what have you. And we worked with them. We finally got her into treatment. She's there now, what have you. So what we do is sometimes we have to use involuntary commitment. Nobody wants to use involuntary commitment. It's an option of last resort, but versus somebody freezing to death or dying of heat exposure, they can't take care of themselves or not eating well. They've got sores on their body. We want to, if we have to, we say use that. Now, the difference with the police department is I can sign an affidavit. I can use my license. I can describe it. I fill out the affidavit. I sign it. I put my license number on there. We call the police for transport, and the police will come out and look at it and go, no, we don't see it that way. We're afraid we may be going to violate their civil rights. Okay. In New York City, if I have a card and I show them my card and I say, I filled it, here's my affidavit, we need you to transport them to treatment, they do it. They don't question. They don't have to do clinical work there. They accept our judgment and they go ahead and transport them to treatment. We have it all the time. It happens here all the time. And you have to talk to any street outreach worker. They'll tell you, we had this all set up, ready to go. Police came and they wouldn't transport her. Got in their car, drove off. And so that happens all the time. So that's something that we've got to, that's one of the things that was one of our big takeaway lessons from New York City. We asked them, we said, does the officer ever refuse to do it? And they said, occasionally. And we said, what do you do? They said, well, we get their name and we bring them back in and retrain them.
Okay. So, but you talk about involuntary treatment, and this isn't necessarily, is it the same thing as that I'm talking about? Is it a high bar to put someone in involuntary treatment? Because I hear from families who have people on the streets that won't go, and they want that. They would rather have
families plead for it.
I mean, we're almost to the point of, I know some people who are so frustrated that they're wanting institutions back. I mean, that's where they are. They would rather, because they're so fearful of their loved one dying on the streets. And so in Oklahoma, do we have too high of a bar for involuntary treatment to get someone stable,
we think it's in the 43A law. We just don't think
so you
it's
think
being
it's
utilized.
There, it's just not being
We think
applied.
It's there. That's right.
Okay.
And I don't really believe that bringing back large institutions is the answer. Now, what they do in New York,
I think they're just frustrated. They're like,
yeah. But what they do in New York, they have a certain number of beds for these individuals we're talking about set aside where they can be treated for a little bit longer period of time. And they do not discharge them back to the streets. We discharge people back to the streets all the time, or we release them from jail back to the streets all the time. They don't do that there. So while they're getting this longer treatment, a period of time, they get their housing set up, they get a treatment team, a PAC team ready for them. And so they're discharged, not back to the streets. They're discharged when they're ready. They're discharged into housing with a team wrapped around them, waiting on them to be there. And they're having good outcomes. And we think that we need to be looking and trying this type of thing here in Tulsa. And by the way, we've heard, I just heard this morning, Matt Altum and Kelly Wilson and Noe Rodriguez at Tulsa Day Center, and Kelly's over the blue team. They're having a conference call. The mayor's office read our story, and they've called, and they're having a conference call this afternoon to discuss what did we learn in New York, what do we need to look at. So we're very hopeful that our mayor's office is finally kind of like, okay, maybe there's something here for us that maybe we are overlooking or we don't know about. That's totally understandable. Totally understandable.
Right. I mean, and this is a community problem. Let's be very clear that this is not the mayor's fault. It's not
the mayor's
fault. We all have a vested interest in making sure this runs effectively. But you mentioned something just now, which is housing, that we're releasing too many people to the street. First of all, they're not being taken through this involuntary treatment. And when I ask the question, how do you solve homelessness? The answer consistently is housing, housing, housing. But we're talking about a group of people that just giving them a house isn't the answer, because they aren't well enough to maintain that alone, that they trash it, they go off their meds. So when you talk about a team, how does Oklahoma or Tulsa even have the workforce infrastructure to have that in place for every person, that if we were to provide a shelter, apartment kind of situation, that they would have that sort of support system? And if we do, what are the obstacles? What's happening? Why can't that
we
be?
have four PAC teams in town.
Four PAC teams.
Again,
Okay.
in Tulsa, we're talking about 20, we think, and we've talked to lots and lots of outreach workers. We think there's about 20 to 30 people that are in this subset. Again, as we said earlier, that these individuals are, for homelessness related 911 calls,
Right.
It's about 70 or 80% of those calls related that are homeless related for this one group.
To just this like 30 individuals. Okay.
30 people. Now, I got to believe that those four PAC teams, and that we could have 30 small apartments, and that can handle both across those four PAC teams. We could handle those people. And we also think that there's enough beds. If not now, we're getting ready to build we're building a new hospital. It's going to have a lot more beds. That we could have some beds set aside that people could be treated for a longer period of time. When I say a longer period of time, it might be 30 days. It might be 60 days, not forever, not for long periods of time, but until the chance to figure out how can we bring that person up. Anosognosia may not go away, but their other symptoms can be better and they can get away, and we don't. But if we discharge them back to the street, what happens? Guess what? There's nothing wrong with me. I don't need to take this medication. And They stop taking the medication. And so that's what the DSM-5 is saying now. I quoted it in the article. It's written there in the Diagnostic and Statistical Manual of Mental Disorders. It describes it. Thought to be a primary cause of rehospitalization, because there's nothing wrong with them and their minds, and so they don't take it. But if we have a PAC teams are designed to go be there every day if necessary, sometimes more than once a day if necessary. And that's our best chance with this. We think this is our best chance with these 20 to 30 people who create so many problems and are so ill. They're the most vulnerable people within the homeless population. They're the most vulnerable that there are in that population, not just here in Tulsa, Oklahoma, in every city across the country.
And I just say that there will always be this, that just because we get this current 30 people off the street, there are always going to be people coming up. So I see this model as always being needed.
There will be.
It reminds me, and you were the one who brought this to my attention. Remember $1 Million Murray? You gave me this article. And I looked it back up and reread it. It was a Malcolm Gladwell story in the New Yorker from 2006. And just to sum it up, he followed a guy named Murray in Reno, and he chronicled the last 10 years of this guy's life. And it was just a revolving door. He would probably fall into this group, this anosognosia group. And it just, emergency room, arrest, emergency room. And just as the article showed, he estimated it cost him taxpayers about $1 million for Murray's existence in 10 years. And it also mentioned in there that and some police officers, were involved with studying this, that 80% of homeless people do get their lives back on track, but it was just this 10 to 20%. And so here we are 17 years later, Tulsa still has Murrays on the street. And so looking back on it, you were at the Mental Health Association for a long time, and you built up, by the way, and I'm going to brag on you. You took a $350,000 budget and a staff of 5 when you started. And I think largely through your housing program, you built it up into a $10 million budget and 150 something staff.
$20 million budget.
$20 million. Okay.
Total annual budget of $20 million.
That you were providing services. So looking back on that, here we are as a community. What did we do right in this time, in this last 20 years? And what maybe did we not get to? What couldn't we do or didn't we do to where we still have Tulsa's Murrays on the street? I mean, the right and the wrong. overall.
Well, remember, for example, last year, this is a point in time count, Away Home for Tulsa data, Housing
Right.
Solutions data. 400 people who were homeless last year were housed. 400.
Mhm.
That's not bad.
Mhm.
Uh, and and I don't know how many it'll be this year. We'll know, but people are still getting housed all the time. But there are people who those are people who are they've got their ID. They're ready. They've either through rapid rehousing or one of the HUD programs that exist in our community, they've been able to get connected up with services and get into housing. And so we've done a lot of great things, but this subset of that population, we're failing us, our our community, Oklahoma City, Dallas, Kansas City, Denver, LA, everybody's failing with this population. But here is New York City, and they're trying something, a different approach, and they're starting to have some good outcomes. And I was trained under a clinician here in town, and it's an old adage, and I'm an old family therapist, Jenny. If what you're doing is not working, try anything else. And and so we're failing with this population over and over again. And we have all these. This is the thing. We have all the pieces in place to do this,
Uh-huh.
but they're not. We're not on the same page. Police is on a
Okay.
different page.
Okay. So that's very
Police is on a.
optimistic. I mean,
Huh?
that's good. You're saying that when you look at Tulsa, that
Yeah.
we've got the infrastructure, we just need to apply it differently.
We got to get on the same page. That's what we saw. That's where the mayor's office out of New York is saying, "Police, you're going to have to you're going to participate with this. Housing providers, homeless outreach teams, we're going to get all on the same page here. We're going to understand how we're going to do this and how we're going to work together on this." And we went from the mayor's office in the morning, and we went to Bronx Works in the afternoon, and we talked to the guys that are down there on the streets in Bronx Works, and they said, "Oh yeah, we're totally on board with what the mayor's doing. We totally support it. We get it. If we're going to help this population, this is exactly how we have to do it." We didn't talk to anybody at the police department. But they told us out of the mayor's office how that works with the police department. So everybody's on the same page, and the hospitals there again. They said, "Well, we have a big advantage over you. We have some large public psychiatric hospitals, but it's all relative." But we do have some public beds here in Tulsa, and we're going to have more soon. And so, what if we we set aside and we begin to, but we've got to work and communicate together, and we've got to all be on the same page, and we're not. Everybody's kind of still, even with Away Home for Tulsa, we're all still kind of doing our own thing. And we're here saying, with this population, if we're going to have success. And by the way, we went up and did a training for our civil commitment judge, and I'm so embarrassed. I'm blanking on her name right now. It used to be Judge Pace, did it for years, and they have a new judge. I'm so sorry. I apologize if she's listening out there. But we went up here and talked to her. We started talking about what anosognosia was, and she goes, "Oh, we see that all the time." I said, "Yeah, we know it." And she said, "Can you do a training for my staff and my deputies?" We said, "Sure." And Kelly did. We did a training for them. So that's about it. All of us, we've got to get on the same page. We've got to understand. When we met with the mayor's office, I mean, the first thing this guy, who's the mayor's top person on homelessness, it wasn't very long at all. He started talking about anosognosia. Well, we're dealing with people that have got anosognosia, and that's one of our most difficult groups of people. That's what we're trying to do here. And then when we started talking about it, they were like, "Hey, you guys are on it, man. It's pretty good, pretty cool." And so we had a great.
In knowing that what the symptom is, you're saying it does change the way you approach those people? Is it in the treatment, or is it just like, can you give me an example of how knowing what this is changes the approach or something?
We're still going to try to build a relationship with them. Like the woman who was outside, I won't name the business, right, downtown, and just here recently, she went down there every day. She met with the business owner, and they were working together. The business owner, they had called the police several times. Police said, "No, we don't see that. We don't see it." They wouldn't. They drive away. Business owners frustrated. That's when they called Kelly, a blue team. Kelly goes out there every day. She's trying to talk to her, trying to build a relationship, goes back every day. They're giving her food, they're talking to her, but it did not reach a threshold where she would say, okay, I'll go to treatment. So we used the involuntary. Kelly signed an affidavit. Fortunately, when the police came this time, they showed the affidavit. She had signed it, put her license number on there, and they took her to treatment. So now what we got to do is not release her and discharge her back to the streets. I visited TCBH not very long ago. It's been a few months ago. And I met with the administrator there, and I was leaving, and they walked me through an area, and she said, well, this is a guy we're getting ready to discharge. Okay. So I go out and get in my car, and I'm at my car doing what we often do. I'm reading my text, what happened while I was in a meeting, what I missed, looking at my emails real fast. And then I'm pulling out, and there he is standing out there on Harvard with his bag of clothes, looking up and down the street. Really?
So we're back to the beginning. And that's what I'm saying. We're back to million worry. We know this is where this is going to end. So in that case, you're saying that now, if everyone can get on the same page, there is an apartment house somewhere for him, and a team that shows up every day and makes sure that he's taking the meds, he's aware. Does it ever help with the person to say, hey, you've got anosognosia, this is what this is? Does that ever make a difference to people?
I don't know. Really? I don't think so. I mean, it's so hard. It's really hard to get our minds around. It'd be like if I said, I mean, I'm licensed here, Jenny. I can tell pretty easily. I don't think you have a mental illness. I'm pretty confident about that. But what if I started telling you, Jenny, you've got a mental illness. Jenny, are you hearing me? Do you understand what I'm saying? You go, I don't think I do, Mike. I don't know where you got your license at, but I don't have a mental illness. And, I think you have schizophrenia, Jenny. You need to go to treatment. We're going to come down there. I'm coming down there right now, and we're going to get you some help you need. You need to come with us. You're going to go, Jenny's going to go, Mike, if I have to call security on you, if you come down here, I'll do it, but I don't have a mental illness. So it's really hard to get our minds around. I see where that
can kind of escalate. Yeah.
So it gets people very agitated.
So when does this start? I know that because I have 2 teenage kids, and I'm super hyper aware of the mental health needs of kids. And I know that some mental health disorders start presenting sometimes in young adults. Does this anosognosia present along with that as the mental health disorder might present, or is that something that might come along later in life?
It can be with schizophrenia and schizoaffective disorder, very common onset. There are exceptions, but generally, by many high percentage, onset is late teens, early 20s. Okay, and usually anosognosia will come right along with it in the cases that it's going to come along with. Okay. And I hope to find out when we have Dr. Amador in to learn more about some of the development, if it gets worse or is it change. Now, again, interesting with bipolar disorder, people will have oftentimes a pretty high percentage of people with bipolar disorder when they're in an untreated state. Now, I'm talking about bipolar 1. They're in a manic state, and the data shows about 60% of them, when they're sick, when they're ill, they're symptomatic, they'll have anosognosia. They won't recognize it. But it's interesting when they get treatment with bipolar and their manic phase retracts, the symptoms abate, their anosognosia symptom will go away.
Okay, so that I can see. So then they will accept treatment. So it's a little easier to treat if they'll recognize it at some point.
Yeah, I can't wait. I can't wait to ask Dr. Amador. I'm going to get to interview him as a part of this. I can't wait to interview him about some of these questions so we can get some of the blank spaces filled in trying to understand it.
And for me, when we talk about mental health, it seems like our community, and we are talking about the most difficult to reach people. That's been our conversation. But part of me is always worried about why are we're always trying to we wait too late. Like, I'm always interested in the prevention. How do we prevent someone from getting to that point? And it's like this big spectrum or continuum of, if a kid, and I go back to kids, that's kind of the world I live in, a kid has to be in crisis before they get care, within months. And it's almost like overwhelming to me when we talk about the mental health system and where do you start? Because the priorities of things, yes, these anosognosia, people who are on the street and hurting themselves and others, definitely the priority. But in taking a step back, and this is just kind of the theory here, when you think of a well-resourced, effective, thriving mental health system for Tulsa, what do you envision? What would you say, this is it? This is where we need to be?
Well, I think we're getting there. I mean, with the work that Family and Children's is doing, the work that Grand's doing, and by the way, a lot of people still in the community don't know about Grand moving in beginning in Cree Oaks, and then the new the VA hospital and the new TCBH is going to convert. It'll be downtown also. The work that OU's doing. I mean, I think we're really getting there, but we still have to have, with this particular subset of the homeless population who don't want your help. They don't have anything wrong with them. We still have to have strategies and approaches into understanding what this symptom is and what a barrier it presents. And by the way, back to your prevention, there is a strong movement. I know Family and Children's has had a grant related to this. I don't know the current status of that, but what's usually referred to or something like this, what's called first episode. So the thinking, and there's research to support this, that when someone in their late teens or early 20s and has their first psychotic break, that if you can get treatment to them very quickly, that it limits the damage that occurs to the brain. But if you keep letting them have episode and they quit taking their medications and they get sick again, or if they're treated, they're not getting the treatment they need, that over time the illness becomes, it takes more medication, more complex cocktail medications, and it's not as responsive to treatment as it is when you catch it on a first episode. So there's been research, and NIMH, in particular, National Institute for Mental Health, has been very big and involved in funding first episode research, so people get all that, in their families get all that they need on that very first episode. So that's a preventative piece that I think we're doing better on.
That's so interesting, because that reminds, it's like everything, like early prevention, whether it's cancer, heart disease,
doesn't matter.
And going back to Dr. Bob Block, he was on our community advisory board, and he was insistent almost that we call this brain health. He said, mental health, people get this idea and stigma. He goes, this is brain health. He goes, it is no difference. Right. He goes, and it reminds me of just like early treatment of a brain episode. It's like, it just makes common sense. If we could just
give a brain disorder, brain illness, don't treat it, gets worse.
Right. So it just reminded me of Dr. Block when he was talking to us about this. But I know that we need to wrap up, but you had mentioned that you're going to interview the doctor when he comes here. And I want to promote your podcast, which I just started listening to. You've done 15 episodes, and it's on Spotify. Any other places we can find it?
Apple Music, other podcast platforms. It's just about on all of them, wherever you find your podcast platforms. All Things Mental Health with Mike and Joy, and Joy spelled Joi. My co-host. I did the first ones just All Things Mental Health with Mike Bros, but now I have a young, smart, brilliant co-host, Joy Rhodes, and who I think I've gotten a lot of feedback that just people saying, Mike, she just makes it even better, and I totally agree with that. And
well, the topics are fantastic. And I'm saying anyone here who cares about mental health, you need to start making your way through these, because you speak to everyone from Zach Stoikoff to the Healthy Minds, this District Attorney Steve Kunzweiler, Dr. Kathy LaFortune, who's brilliant, and we get into the Forensic Center, which is a whole other hour.
Yeah.
To me, and I'm really interested in the ones I haven't heard it yet, which is the spiritual trauma
Social trauma.
which is the intersection of where faith and mental health can come together and sometimes create a lot of trauma. So
Yep.
I hope faith leaders find their way to that. But
I do too.
This is a fantastic podcast. I cannot think of a person better to lead this than you. So thank you.
Thanks, Jenny.
Great. So everyone watch that and read the op-ed and learn more about this symptom and what's going on. So I just want to say thank you for your time. Between people don't know this, but Mike and I could probably go on for about 3 or 4 hours. So we have to stop to it at some point.
Well, I just want to thank you, Jenny. And I've told you, I'll say it on your podcast, we need journalists. And you guys are down the world are fantastic journalists. It's been an honor to be on the advisory group this year. And I just appreciate that. And man, how important it is for our community and state to have top flight journalists like yourself. And I just want to congratulate and honor you for that, Jenny, and your team over there.
That. So any last words you want to give us on mental health? Any last thoughts you want to leave people with?
Well, I just like people to be open to what we're talking about with the Blue Team Initiative and what we're trying to do here. And I want to say also just thanks to Mac Haltom at the Tulsa Day Center. Mac and I started talking about this population, this subset of the homeless population, over 15 years ago, walking around the streets, taking our exercise walk in Washington, D.C., when we were attending the National Alliance to End Homelessness National Conference. And we were just reminiscing this morning about that. And that's where it started with he and I in this conversation.
Yeah, and Mac at the Day Center, he's been there, I think, for as long as I've been
long
here.
Time.
It's a long time, so he knows what he's doing too. And
he does.
The initiative is all about a study of this subgroup, just to
getting them help, getting them treatment, getting them off the streets.
Exactly.
And let's find out what we can do here. Let's try something different. It's not working what we're doing now.
Right. So, well, thank you, and everyone, find his podcast and read the op-ed, and we will see you next time. Thank you.
Thanks, Jenny.